Scoliosis affects around 4 million individuals in the United States and is the most common spinal deformity in school-aged children. Sadly, modern scoliosis surgery is a major procedure with a high rate of complications, including death and paralysis. Clearly, there is a need for a less invasive form of treatment. In this minimally invasive form of surgery, a small incision is made at the top and bottom of a spinal curvature. A modified pedicle bone screw is then placed at each location. A third incision is made lateral to the apex of the spinal curvature, exposing the underlying ribs. A Jamshidi needle is inserted and directed toward the lateral spine. The needle is then gently tapped across the apex vertebra. Care is taken to avoid the pleura of the lungs. The Jamshidi is advanced across the vertebra until the tip barely protrudes through the contralateral side. The stylet is then removed. An inflatable bone anchor is then inserted through the needle shaft until the tip protrudes on the contralateral side of the vertebra. The anchor tip is inflated with a material that solidifies within minutes. A stable construct is formed, serving as a strong anchor that can withstand force. A stabilizing plate is inserted through the lateral incision and is affixed to a rib with screws or clamps. This plate acts as the confluence point of the surgical force vectors, while its upper component can mobilize to a limited degree along the rib. Two contoured rods are inserted through the lateral incision and passed subcutaneously. The superior portion of the stabilizing plate has two depressions where the rods are secured and able to rotate. The ball tip of each rod is secured in its associated pedicle screw with a cap. A midline incision is created at the apex of the spinal curvature to allow the cable winding mechanism to be affixed to the spinous process. Once the connecting rods are in place and the winding mechanism is secured, the traction cable of the balloon anchor assembly is placed around a pulley situated at the center of the stabilizing plate and fed subcutaneously to the cable winding mechanism. A locking plate is then affixed to the stabilizing plate to secure the pulley and capture the balls of the connecting rods. The traction cable is connected to the winding mechanism so that when the depression paddle is activated, the cable gradually winds and tightens. The incisions are closed, leaving the pressure tab of the cable winding mechanism apparent beneath the skin. Over a period of time, the tab can be repeatedly depressed, pulling the apex of the curve toward the stabilizing plate, which transfers the vector force to the connecting rods. The rods exert pressure on the upper and lower segments of the spinal curvature. As the spine gradually straightens, the rods slowly rotate at their connection sites, eventually changing the force exerted from a perpendicular pushing force to a parallel traction force. Meanwhile, the rib plate shifts medially to adjust for vector forces. The traction force provided by the cable winding mechanism is converted to a pushing force to align the spine. In effect, this system acts as an internal adjustable brace that optimizes force vectors without the problems associated with traditional braces. Once complete alignment is achieved, the system is left in place until skeletal maturity is reached, at which point it can be removed.